Well, can I extend that very warm welcome to London, to the conference centre here, to all of you from all the 4 devolved nations of the United Kingdom, and from those of you from further afield from all countries around the world. We're going to run this session. We're going to have 3 talks, very high-profile speakers who are each going to speak in turn. So save your questions. We've got a panel session at the end when they're very happy to take any questions from anybody in the audience. So if you've got a question for them, write it down. Don't forget it. We won't lose it. We're going to start with Richard Murray, who is Chief Executive of the King's Fund. Richard has had he trained originally as an economist, and he brings the strength of having both been in the private sector with McKinsey's and consultancy, and also in the Department of Health in government and in the NHS, and now Chief Executive of probably our leading charitable organisation that is an independent does independent analysis of how the health services are functioning. And when I became chair of the General Medical Council, early on, there were a few people I wanted to see one-to-one to really try and set the landscape for me. And Richard Murray was one of the people I asked if I could meet with him then. So I can't give a bigger accolade than that. So Richard, we're looking forward to hearing from you. Thank you.
This is the first in-person conference I've done for a long time. So if I stop speaking, tell me to switch. I'm still on mute. This is quite a challenge, actually, to do the health and care landscape at the moment. I've had a long career in health and care, and I don't think I can remember, certainly during my career, such a busy time with quite so many moving parts that we can see at the moment. So I'm going to try and give you a kind of a potted run through, but probably each slide could have been expanded into half a dozen that sit behind it. So I hope this still helps you. I'm going to talk in 3 particular areas. Can't ignore the recovery from COVID. I know we're going to be talking a little bit more about that after me. Issues around health, around waiting times, of course, but recovery from COVID, I think, over the last year, I think we've realised how much of a long slog this will be, just how difficult it's going to be. At the same time as the operational challenges you've got within the service, both in health and in social care, we've gone back to reform. So there's a health bill just moving between House of Lords and going back to the House of Commons. It's easily the biggest legislation since 2012, and depending on your perspective, you could probably go further back than that. But it's not the only piece of reform that's going on. After something like 10 years of governments thinking that large-scale health reform was a no-go area, the government seems to have got an incredible fondness for moving the pieces on the health and care landscape. So I'll touch a bit about the reform agenda, and also what underpins all of this. Of course, health and care is a service industry, and all service industries are unbelievably dependent upon their workforce. And came into COVID with problems, long-standing shortages in both health and social care, and those problems have not disappeared. They've changed over the last 2 years, but they've not gone, both picking up issues around morale, retention, but also around just how many people we've got in the system to try and deliver care. So those will be the 3 areas that I'm going to try and cover. I'll do the negatives from COVID first, but of course there are positives of things that we've learned, but let me just run through some of the negatives. The direct impact on people's health and well-being, it's taken off on ONS last numbers more than a year of life expectancy, both for men and for women, quite a bit more for men, by the way, than for women, as mortality in men was quite a lot higher. And it affected social groups in a very different way. So it also shone a light back again on very long-standing inequalities. We know that they've been there, but once again, COVID particularly picked off those in deprived communities and those that couldn't work from home, basically. So often, unfortunately, health and care staff as well. We've a slightly unknown tail of long COVID. Its symptoms mimic lots of other symptoms. It's not actually at that moment quite easy to tell what the long-term impact on a minority of people will be from COVID, but it's certainly there, and it's one more of the uncertainties that we're seeing. We've got long-term impacts of ventilation. Fortunately, the United Kingdom was one of the pioneers in research around COVID and learned quite quickly that you didn't need to use such invasive forms of ventilation. But for those that did go through that, it's not something that you recover from quickly. But I think it's the indirect impact of COVID that we're still uncovering and still beginning to understand now, and we're still going through that process. So late presentation, a lot of people did not show up that would have shown up. NHS England's estimate is about 10 million people would have been referred into secondary care that didn't appear in the system. And if I'm absolutely honest, we're not sure where they are. Are they coming back? Have they got worse? Did they get better? Did they go private? Did they find some other way of supporting their health? We don't really know. Some are reappearing in the system, unfortunately, particularly in cancer pathways, as you might expect. If you appear later in the pathway, you will appear sicker, and it will alter what can be done for you. And we still don't know. So you may have seen NHS England's committed to a new set of waiting times targets, but they've said that they will review them again in the summer. And that review point is how many of those patients are coming back in. An optimist would say, it depends which side of the coin you are, an optimist would say that they'll all come back because they need health and care. Unfortunately, that will balloon the waiting list if they do. People that were already being treated, pathways of care were interrupted. It depends where you were in the system as to how severe this was. We're beginning to pick up now, I think, some examples, particularly in mental health, where people that were on a care pathway on mental health are now facing difficulties and begin to understand the impact that it had and the impact of lockdowns themselves. Again, this isn't something that we can dot the I's, cross the T's yet, but the appearing evidence seems to point that it's particularly children, health and well-being of younger people, that the lockdowns and school closures and the strangenesses that we went through, that's where the bigger impacts lie. Unfortunately, before we went into COVID, child and adolescent mental health in all the 4 countries of the United Kingdom was already in a fairly parlous state in many parts of the country. And so, unfortunately, it's leaning on one of the areas where we're weakest. And we've still got a productivity hit. So particularly from infection control, so that the numbers of staff, I've spoken about workforce and I'll come on to this again, the numbers of staff in the hospital sector is rising, and yet we're struggling to treat the number of people that we treated before we moved into COVID. A lot of that, again, is around infection control. Absolutely appropriate, but it really does slow down the system. I should say a little bit about the positives, because this is a slightly negative view of the world. Where were some of the positives? To point out the obvious, the use of digital. We often talk about a lot of digital contacts through the system. A lot of it was telephone, so not quite the cutting edge of modern technology. But nonetheless, a huge kind of channel shift, both in general practice, which has been quite controversial, but also in secondary care as well. Many providers began to cooperate in a way that we've not seen before, so changing care pathways happened in London around cancer to try and maintain the throughput of patients, try and make sure that they were safe as they did it. So changing the way that we deliver care, which has always been a struggle in the NHS, is often controversial, but that moved forward. And many of the relationships improved. So the work between different individual trusts, between trusts and local government, often between the NHS and social care, and often between all of them and the voluntary care sector. So things that we've spoken about for many, many years as being integrated care, that gold standard that people wouldn't notice as they moved from one provider to another, from one part of the system to another. Not universal, but in many parts of the country, what's come back very loudly is that moved forward at light speed during COVID. And people may wonder why the government's gone for large-scale reform at this time. At least one of the reasons is they wanted to try and cement that change in behaviour into law before we all went back to business as usual. Unfortunately, 2 more waves of COVID popped up before the bill actually appeared in Parliament. And again, we've seen how the NHS at scale can do things, sometimes helped by the use of data. The vaccine programme is, of course, one of the shining examples. The thing that you can easily point to some other countries that have higher vaccine rates than we do, but it's often led by the fact that they vaccinated children as well in the way that we didn't. If you look at the key population, which is the vaccination rates in older people and the vulnerable, the United Kingdom, the NHS did incredibly well, and it did incredibly well at great pace, despite the fact it was in the middle of the pandemic. And the power of data, the power of the cooperation between the NHS and local government directors of public health, and reaching out into faith groups, into wider parts of society to try and make sure that they could get vaccination rates up as high as they could. And that's proved unbelievably powerful. If you want to see what happens if you don't do that, Google Hong Kong at the moment, and you'll see just how shocking Omicron can be if you meet Omicron without having vaccinated older people to the extent that we have. So lots of pluses, and that's just a few. So it certainly isn't all bad by any means. And one of the goals, of course, is try and bank some of those wins, bank some of those gains, and not lose them as a slight fear that we'll go back to business as usual if we don't book some of these gains. I should also mention the research effort. The United Kingdom was outstanding on developing the research effort, despite the fact our hospitals were often full of COVID patients. It didn't stop clinicians working together, and so we punched way above our weight on the research contribution around COVID as well. The workforce. The top line is the number of nurses. I've indexed them. Going back to 2015, the bottom line is the number of GPs. So to start with, if you want to know why GPs are angry and you can't get an appointment, well, if you have less GPs and demand goes up, the consequence is you won't be able to get an appointment. It's not rocket science. And if I can't go back before 2015 because we keep on changing the data sets on GPs. So we even, in fact, there's multiple changes in definition even since 2015. If you can't even count the number of staff you've got, then again, don't be surprised if it's easy to drift into a workforce crisis. There are many more other staff beginning to work in general practice, physios, pharmacists, and so that the total number of staff is going up. But at least for the moment, with a service that's very dependent on the number of GPs, and by the way, nurses, because the nurses in general practice also are not doing well, this explains some of the stress that we're seeing in the system. The team leaders that you rely on are getting rarer. And in fact, it's probably lower than it was since 2009. That's a typical piece of stats. But if you just think about that with the increases in population and the increases of need, that's well over a decade of declining numbers in general practice. There were shortages before COVID. Obviously, it was a big feature in the Conservative Party manifesto, commitments on the number of GPs, commitments on the number of nurses, commitments on those other staff that you could use in general practice, physios, pharmacists. It looks at the moment that they might hit the nursing target, a million miles off the GPs one, and some struggling around those other professions. Because if you're changing the makeup of general practice with these new staff, you've got to think about team building, you've got to think about OD, how are you going to do it? And so a major change in the model is quite difficult to pull off. But the numbers of staff in hospital are going up. I mean, particularly for nurses, it's taken a long time for that line finally to start going in the right direction, but it is now beginning to go in the right direction. The number of hospital doctors is going up. Why are we struggling? It's probably that same productivity point. It's the same productivity point that even if we have got more staff, they're trying to deal with more demand, and the productivity, mostly through COVID, is still struggling. And that is where we're kind of stuck right at the moment. Will the numbers of staff keep on going up? COVID was an incredible shock to many people working in health and care, and not in a good way, for most staff. Some, by the way, were kind of re-energized by the crisis, but many weren't. And particularly sometimes using trainee staff in the front line, probably a bit before they were ready, is a very frightening experience. And some, I think, have learned from that this isn't a job that they want to keep. And we've brought people back into the workforce that may not really be intending to stay in the long term. They came back and held on in the service through the crisis of COVID, but delaying retirements and doing the right thing. So we're still waiting to see quite how this begins to feed through in the numbers, but people will know inflation's going up, the government doesn't have the room for manoeuvre for a big pay rise, staff are often feeling jaded, and some of the shortages that we're seeing sit in social care. Again, the data's not as good in social care as it tends to be for the hospital sector, but there's a real problem around the social care workforce, and the other hit around productivity is struggling to get people out of hospital. We don't want to focus too much always on the hospital sector, but it's where the data's best, so it's incredibly difficult not sometimes to focus on the hospital sector. This is the big thing. This is the big thing sitting in front of, I think, every service in the country. It was the biggest thing facing health and care in 2019. It's only got bigger. And unless we can find a way through the workforce issue and productivity, then all the reform in the world is going to really struggle. This is such a simplified chart of trying to explain the new reformed system. So I'm going to have a go, but one of the things about the reforms to understand is they're very permissive. So they've allowed local areas to retain their geographies, how they've defined themselves. There's not some kind of great big cookie cutter sitting in the Department of Health, which is what we've done in the past and said a CCG will be almost between this size and that size, and here are the rules. It is much more permissive about how these structures evolve, and consequently an enormous amount of variation. But putting aside that variation for one moment, we have the giant of NHS England. Everybody's being merged into, not everybody, many organisations being merged into NHS England. So instead of being one of a large number of powerful arm's length bodies in 2012, it's really, with CQC, the only people left. NHS Improvement, NHS Digital, Health Education England, all going into this giant ALB. England is then divided, and sorry because this is a slightly English view, 42 areas. These are the integrated care boards. They've grown out of STPs before them. They vary enormously in size between Frimley at one end all the way up to the northern, northeastern North Cumbria, which crosses between the Irish Sea and the North Sea. London has 5. They're all quite big. You get down to Cornwall, it's big by geography but small by population. But people have been allowed to some extent to define how these work, what size and shape that they are. And the bill is fairly relaxed about how they're organised. So they will become into statute, they will be legal organisations, CCGs get abolished. These are the people that will hold the money in a kind of old-fashioned commissioner view of the world about how the money's allocated. But it's a fairly permissive approach to how these will work and the populations that they cover. And then beneath them are, it's one of the most confusing phraseologies ever, but this is place, the place-based partnerships. If you're in London, it's a borough. If you're in Manchester, it's a borough. So they're often on local government footprints. It's where a lot of the heavy lifting of integration is meant to happen between health and social care. A lot of the integration with general practice, because ICBs are often just a bit too big. They're not going to be often getting involved in very local decisions unless perhaps you are Frimley. But certainly the bigger ones wouldn't be doing that. And in a lot of ICBs now, they could easily show you where their places sit. And as I say, for London, it's blindingly easy. If you get to Norfolk, it gets harder because they don't have such an obvious local government structure to build on. So sometimes they're using older NHS ones. They're largely not in the bill. So the legislation deals with NHS England. It deals with the ICBs. I don't think it mentions place once. So again, it reflects the amount of freedom that's being given to local areas to try and work this out for themselves. But the integration white paper that came out in February did actually fill in a lot of the missing gaps around place. So if you want to know how place is supposed to work, that's where it sits. And of course, providers still exist. A lot of NHS just merging or sharing leadership teams, but they're still there. But the provider side is changing too. So, and in a couple of important ways. Provider collaboratives are forming. So trusts are coming together to work across much bigger footprints. Some of these actually dwarf their ICBs, so there's supposed to be one per ICB, but some of them stretch far further than that, particularly if you've got big teaching hospitals sitting in them. These are supposed to be targeting things like waiting times, sharing best practice, working together sometimes on workforce, on back office functions. And so provider collaboratives have appeared, and of course we still have primary care, and a bigger role, I think, for the voluntary sector in particular. It's often quite contentious, but the voluntary sector did deliver a lot of care through COVID. It's been an ambition for a long time to bring the voluntary sector and the NHS closer together. It's often been quite difficult to do, but I think some real gains there. This, looking at the reform structure like this doesn't really tell you what's really meant to be different. This looks quite a lot like a commissioner-provider split, the kind of systems that we've seen since 1990 when providers began to be separated out. They're meant to be closer to partnerships. So providers will sit on the integrated care board, they'll have one seat. A local authority will sit on the board, GP will sit on the board. They're supposed to be working together using collaboration and not competition. So the previous 30, 40 years, since 1990, has moved towards competition and autonomous organisations kind of looking out for themselves. This is replaced by a duty to collaborate, by a triple aim that says what everybody's objective is, improving health, providing good services, delivering value for money, and it's a move towards this more collaborative model. It does get tricky when you're signing contracts and you're handing money out. So this is one of the things that you can't legislate for that, and there clearly are risks about conflicts of interests. How will providers work within this system? How is this going to be? And the leadership of the NHS in particular has grown up under a very, very different world, not one that really focused on collaboration. It's one that focused much more, I'm going to say competition. I think competition was exaggerated, but you looked after your organisation. Your responsibility ended at your front door. That's probably a better way of thinking of it than true competition. So that's the reform structure. Should come in July. The bill, some important changes, is going back to the Commons now, but this basic structure I don't think is going to change. That's not the area that the excitement and the conflict is over. The view that we want to do integrated care and that we want to focus on the health of the population, I think, is a common objective for most of the health service, local government, and indeed, I think, parliamentarians. So that core element to it, unlike 2012, isn't really so controversial, and we haven't seen people demonstrating down Whitehall, which we did in 2012. It would be nice to stop there, but I did say there's a bit of a floodgate that's opened up about reform, and I haven't actually put them all down because, particularly the ones that will be coming next, but a real fondness for white papers and for a reform agenda, again, coming out of the government after a very, very long period when reform was done by NHS England. So 5-year forward view, long-term plan, were all NHS England documents. The balance has moved back into the departments. We've had a delivery plan on COVID to try and reduce waiting times, the Levelling Up white paper, probably one of the longest white papers I've ever come across, but it's got important things in it on health. The integration white paper that fills out what's going to happen at place level. We've got the disparities white paper coming in May, local government elections permitting. That's disparities is the new phrase for inequalities. So this is the inequalities, what you would once would have called the inequalities white paper. We've still got the bill, actually just left the House of Lords now. They've done fundamental social care reform, the first government in England to grasp this. Well, the first government in England to grasp this. That was a full stop. There wasn't a comma after that. I know Scotland and Wales did it 20 years ago, but in England, this has proved to be a continual thorn in the side of parliamentarians and reformers. The government's done it. And there was also a social care white paper on top of that as well in December 2021. And there's more talk about policies coming on cancer, on CVD, of disease-based approaches that we were used to in the past, and possibly a workforce plan. Slightly mysteriously, there may be none, or there may be one, or there may be two. There was certainly one coming from Health Education England that looks at the very far future, Framework 15, so not really about the services of today, but NHS England has certainly been commissioned to do one about the services of today, but the terms of reference isn't in the public domain, nor really a timetable either. So the one that we really do want is the one that seems to be furthest down the line. I think there will still be more coming. We know Secretary of State made a speech about his 3 Ps, so prevention, personalisation and performance, and he said, well, there might be a 4th, people, but I think that again reflects the slight confusion over what we're doing on workforce. So you can expect more to come. We have a reforming Secretary of State. To bring that together again, so operational pressures on the NHS and social care, I think the like of which we haven't seen since the 1990s, when waiting times were really at their worst. For a lot of managers, this is not something, and leaders and patients, this is not something we've experienced in this country for 30 or 40 years. And that's on the elective pathway, but the same is appearing in other pathways too. A very busy reform agenda. So for a lot of leaders, as they're thinking about their 2-year waits, about people sitting in A&E, about patients coming through GPs, and about mental health, they're also thinking, in some cases, am I going to have a job in July? Should I be dusting down my CV? And trying to think through quite complicated governance arrangements, which the government has kind of left to local people to work out. So there isn't a kind of a rule book that you can just pick up. And potentially yet more to come, both on disparities and the 3 Ps. The only caveat on those which we do know is none of them will have any money. So if money was the thing that you thought was coming with them, that looks like it's absolutely off the cards. So it will be further reform, but without any extra money. And I think, I'm afraid, for the health service, the budgets that we can already see, the ones they've already said, are probably what we're going to get stuck with. So I will stop there.